go ahead and switch with your partner. And then they're gonna give it back to you. Okay, so we're gonna go through this, and then I'm gonna pull up the PowerPoint and kind of go through it briefly. I'm not gonna like just read word for word all the slides, but just point out a lot of the stuff and emphasize the key points there. Okay, and then the rest of the class will have more activities to do. All right, so number one, what epidermal cell type is responsible for producing melanin? Samantha, what'd you get for that? D. Yeah, D, melanocytes. Yep, let the quiz help you, right? Usually the answer's right there, just trust it, trust yourself. So for responsible for producing melanin, melanin gives us our pigment or our color, and it also helps absorb UV rays and helps protect us from getting that like radiation into our system, into our body. Okay, so the melanocytes, they give our skin, hair, eyes color, and they help absorb the UV light. Okay, melanocytes. All right, number two, what specialized epidermal cell plays a key role in immune defense by detecting foreign pathogens? Trina, you get that one? C. Anybody want to help her? Grace? Yeah, it's B, the Langerhans cells, okay? So Merkel's are going to be next one in question 3, so we'll talk about those. Okay, but which ones play a key role in immune defense? Those are the Langerhans cells. Okay, so there's 4 specialized cells in the epidermis. We're going through them. So far we've covered the melanocytes, and now we're on the Langerhans cells. Okay, so what those do, they're in your epidermal, your top layer of your skin, right, just like the melanocytes. And if you get exposed to any pathogen or bacteria or foreign material or something on your desk that you touch, the Langerhans cells are going to identify whatever that is, carry it, migrate it into your lymph system, which kind of runs parallel with your vascular system. Your lymph system is responsible for immunity. It's going to take that, whatever it is, to your lymph system, and then your white blood cells will decide, is this friend or foe? What do I do with it? Okay, so those are the Langerhans cells. All right, number 3 then, now we're on the Merkel cells. So what are those primarily associated with? Amy?
Yes. How about D?
Which one? D?
Yep.
D, all right, UV is gonna be our melanocytes, okay? So we've covered that one, so we can cross that off the list. Now that we're down to 3 choices, Shernay, would you have a guess? B, yeah, it's B, okay? Sensing, light touch, pressure, okay? So all of these things, you should think safety, right? As you're processing all of this information, oh, that's good for my safety, right? The safety of my human body. Okay, so sensing, light touch, pressure, pain, things like that, so that if you're uncomfortable, you can move yourself, right? So that sensation, you feel it. If it's uncomfortable, you can protect yourself and you can move. All right, number 4, which of the following is not a function of the integumentary system, which is also known as the skin? Megan?
D.
Yeah, that's going to be D. Okay, so A, B, and C, the skin does all of those things: temperature regulation, sensory perception, vitamin D synthesis once you get exposed to sunlight, but not production of red blood cells. Production of red blood cells, your kidneys kind of detect when your blood is hypoxic, right? Because remember, all of our blood goes through our kidneys. So our kidneys can tell if our oxygen is low, so it's gonna release a hormone that's gonna tell your bones, your long bones, to make more red blood cells. All right, number 5, one function of the integumentary system is thermoregulation. Which mechanism helps promote heat loss? Jace, what'd you get? Yeah, it's B, sweat evaporation, okay? And if you kind of group your answers, your choices together, A, B, C, and D all go together, and those would be if you're cold, right? If you need to warm up, you're gonna have decreased blood flow to the skin. Your skin's gonna, your vessels are gonna constrict, preserving blood to go to your brain, your heart, your liver, all of those vital organs. Piloerection is just when your hair stands up and you have goosebumps. So it's like a little feather bed for your body. It's a little protection there and helps with warmth. And then shivering is going to increase your metabolism, help you generate body heat. Okay, so all those go together. The one that's going to help you promote heat loss, meaning you're overheated and you need to cool down, is going to be sweat evaporation. Okay, and then this is a good time to just remind you of those 4 mechanisms of heat loss, if you remember from vitals and head to toe assessment. So evaporation is one, and then the other ones are conduction, right? So direct touch, convection, so like with a fan, convection, and then radiation, so like close contact to something, like a radiator. Number 6 then. So getting into those phases of wound healing. So we talked about these with our crossword puzzle yesterday. There's 3 phases. And then remember, for fun, some have more than one name. So which phase of wound healing involves clot formation and the release of inflammatory mediators? Anna, what'd you get for that one?
C.
Yeah, that's C. Okay, so if you look at these phases, sometimes they split them into 4 phases, hemostasis and then inflammatory, but usually you don't see that anymore. They're combined for the first phase. Because really 2 things happen. One, we have to stop the bleeding, but then there's inflammation, and that's expected and normal at first, because that means all the white blood cells are swarming that area so they can clean it up, decide what to do, whatever needs to be done depending on if there's infection or what's going on with that site. Okay, but the first phase then, we have to stop the bleeding, and then it's inflammatory because all of those white blood cells are going to the site. Right, and then another phase here, during which phase of wound healing does re-epithelialization and granulation tissue formation occur? So this would be the second phase. Jeffrey, did you get it?
A.
Yeah, that's A, the proliferative phase. Okay, so the first one is hemostasis or inflammatory. Sometimes you see them combined. Okay, bleeding stops, then the white blood cells swarm. Then proliferative, so new cell growth. Okay, and then the final phase of wound healing, which involves collagen remodeling and scar maturation. So the wound is already healed. It's not open at all. It's covered, but it has to continually get stronger. Addie, what'd you get for this one?
B.
Yeah, B, and it's got both terms in there, okay, remodeling and maturation, okay, so either one. All right, and then the 3 ways that wounds heal. We've got 3 questions in a row. We've got the primary, the secondary, and then the tertiary, so those are all 3 ways that we talked about. So number 9, Gabby, what'd you get for that one? I need my primary intention. Anybody want to help her? Get something different?
B.
B, yeah. Okay, so primary intention is going to be B. The wound edges are approximated, which means they're together. Okay, the opposite of that would be if they're starting to dehiss or open up. That would not be well approximated. Okay, approximated means together. And then there's minimal tissue loss. There's not like a necrotic tissue, like the cells didn't die and waste away or anything like that. Just usually like a nice clean surgical incision. All right, and then the second one, healing by secondary intention, is characterized by Michaela. Immediate closure after cleansing. Anybody want help, Michaela? Tabitha? Yeah, that's going to be B. Okay, so that's going to be like our pressure sores, so it has to fill in. Okay, so we don't sew it shut, it's going to fill in on its own. So formation of significant granulation tissue. Okay, and then our last one, anybody remember what tertiary intention is? Caitlin, you want to guess? Okay, so tertiary intention, anybody think they got it? Gabby? Yeah, that's gonna be A. Okay, so tertiary then It's like a combination of 1 and 2. So we leave it open like 2, but then we do go back and close it. And the reason is usually because there's infection of some type. Okay, so it's a wound that should be closed, but if we close it right now, it's just gonna form an abscess, which is one of our vocab words. So we need to leave it open until the infection resolves, then we can go back and close it up. So delayed closure, not immediate, after infection risk decreases. All right, and then getting into the last 4 questions are types of dressings. So we'll show you these when we go through the PowerPoint pictures. Will help kind of make those connections. The Tegaderm, Tegaderm, you should know what this is. You should be looking at a Tegaderm on your patient every week in clinical. So Tegaderm, who thinks they got this answer? Elizabeth?
It's gonna be B.
Which one did you say?
Is it B?
B as in boy, yeah, okay, B. Okay, so a Tegaderm is just that clear sticky bandage, and exactly like B says, it's what covers your IV site. So it's clear, it protects the skin, it's waterproof. Also, if you have like a minor injury somewhere else, a skin tear, even like a stage 1 or 2 pressure sore, depending on where it's at and what's going on with that patient, maybe Tegaderm would be good for that. So it's like new skin. So you put it on there and it's like a new layer of skin. It is not something that you're gonna change all the time. You wanna leave it on for as long as it can because it's doing its job, it's sticking on there really good. So if you go pulling it off before it's ready, you're gonna cause more trauma. You're gonna rip their skin off. Okay, so it should stay on 5-7 days. Once it starts to get, rolling away, wet, anything, any drainage building up, you gotta change it. But they're meant to stay on for a long time. All right, and then Methylax. What do we think for that? Typically used for wounds that have no exudate, require negative pressure therapy, have moderate exudate, or must remain completely transparent. Everybody think they got that one, Abby? C? Yeah, that's gonna be C. Okay, Methylax, that's that usually tan colored. It's a sticky bandage. It sticks, like the whole thing sticks to the skin, but it's got a little cushion. Okay, so no drainage would be your Tegaderm. Negative pressure is a specific type that we're gonna talk about. It's not transparent like our Tegaderm. It's opaque, you cannot see through it. All right, a wound vac. Negative pressure wound therapy is most appropriate for, Bryn, did you get that one? B, yeah, deep wounds with significant drainage. So if you look through your PowerPoint, it was with the stage 4 pressure sore, sometimes stage 3s if they're really bad. So we'll go through, I'll show you a picture of that, but it would be for a deep wound with significant drainage. All right, and then lastly, which one would be least appropriate for a heavily draining wound? Anybody, Casey?
D.
D, you said? Anybody have a different guess?
C.
D? Yeah, it's C. Okay, so Tegaderm. So alginate goes in a wound. We'll talk about that and I'll show you that. It goes in a wound, so they can have some dressing. Wound vac is for heavy dressing. Tegaderm is just that clear one that goes on our IV site. All right. Hopefully that helped. I like to make the most of our time together because you never know how much time you do or don't have outside of class. So if this is the only time you quiz yourself, I'm glad that we at least did it once. And I talk about this when students come to remediate with me, but I just want to make sure everyone's aware of like the best ways to study. So if you're reading content and reading your notes, like that's like first level, right? Like beginning level. And anybody could say, yeah, I just read it, I know it, makes sense, I understand it. Okay, but until you test yourself, you don't know if you really know it. So that would be second level, taking test questions, doing activities, seeing if you know it. That's second level. And that's where a lot of students stop. And then like third level, like most, how you really know if you know the material is if you can create it. So not reading it, not filling in multiple choice, like can you create it? So like for the last exam, we had 3 content areas, right? We had nutrition, we had fluid and electrolytes, and we had elimination. So like my final time studying to see if I really know it, I would take 3 blank pieces of paper, I would write nutrition, fluids, electrolytes, elimination. what do I know? With no resources, thinking about how we grouped material, if there's stages or phases or vocab or anything like that, what do I know? And just dump it all out and go from there. You can do it on paper, you can do it on a dry erase board, dry erase markers, things that, you can erase and work on a second time. So that is gonna be the best way, the final way to know. All right, so going through our PowerPoint here, so at the beginning of all your slides, you have how it maps back to the NCLEX. So why do I need to know this? And it covers pretty much all of the categories. And then if nothing else, it helps you think of the categories. So like I said, grouping content material helps you remember it, gives you like a frame of reference. So when you're in, an anxiety-provoking test experience or clinical or a simulation or something, you have that framework and you think, well, is it anything to do with this or this or this? So you kind of have like a checklist to go through. Like these are the things as a nurse, as a nursing student that I think about. So basic care and comfort is gonna be one of them. So we think about wound care, but just basic hygiene is a huge part of wound care. So you can change their dressings, but if they've been like sweaty and there's crumbs in their bed and they feel gross, like they're not gonna care that you just changed their dressing. Like head to toe hygiene and skin integrity, like we're gonna talk about over these next couple weeks, is really important. How mobility factors into that, right? Their ability to feel pressure and pain and then make a change based on it. So some examples then, doing our skin assessments. So I know in clinical last week, I got to go in with some of you guys and go into your patients and show you like how you're supposed to start, like your first interaction with your patient and how you're supposed to make the most of all of your time. So beginning to end, you're building rapport, you're assessing their orientation, you're asking them what they ate, you're asking them about elimination, you're looking at their breathing, all of that at the same time. So when we go to listen to the heart, go to listen to the lungs, we're looking at the skin, right? Because we know we have to do all of those things. Planning ahead, if your patient's gonna be difficult or need assistance to bathe and get up to the commode and all of that, you know that you can't do a full assessment until you've seen their full body. So knowing I'm gonna need to plan for help sooner than later, I'm gonna need to get the nursing assistant, especially at this point in the nursing home, your days are a little bit slower. You can rely on each other more. Now everyone's kind of more busy with their patient, so you should be getting to the point where you're enlisting the help of your nursing assistant, right? Because they have less to do now because you're on the floor, so you can say, hey, like, this is my priority for this patient. I know I'm gonna need you for this, so can we go do it now, or what time should I come find you to do it? So you can plan ahead and get that stuff done. All right, we're gonna go through pressure injuries. We've talked about incontinence and how that can affect skin integrity, and then hygiene, of course, is gonna be key. As we've been talking about, it's a safety issue, it's an infection control issue. We worry about wounds developing and then becoming infected and then spreading to other patients, to other staff. So we're gonna revisit standard precautions and the different contact precautions. Okay, reduction of risk potential. So we're getting a list of things that our patients are at risk of, right? So we started with falls, we've talked about infection, we talked about bleeding, we talked about impaired blood glucose, all of those things. And then we're gonna focus now on risk for impaired skin integrity. All right, and then physiologically is like the science, background, anatomy of the body. So what's going on with the skin? What are we looking at with some specific conditions, and what are some complications that we can look at? Right, and then there were just a couple of little scenarios, little patient examples for you to think about. Maybe after class, we're gonna go through the Braden scale, which you guys should have been doing. You did it in your assessment book right back in the nursing home, and then it's part of each head to toe assessment in the hospital is a Braden scale. Right, so you can look at those. And then going into our vocab here, so these are just in alphabetical order. So an abscess is a collection of infected fluid that's not drained. Okay, so it's swollen, it's usually red because of the displaced pressure. Also, if there's infection, it could be red. It's gonna be painful, irritating. Depending on where it is and how big it is, it could affect their range of motion and their ability to move. Okay, so depending on what's going on, this might be treated with oral antibiotics, maybe they need IV antibiotics, maybe it gets to the point where they need to have a provider drain it, like cut it open and drain it and get that infection out of there. Okay, so that's an abscess. Bandage or dressing, those are just interchangeable terms for the things that we cover the wound with, and it varies. Our friends are gauze, right? We have 2x2 or 4x4 gauze. We always have gauze in our pockets. We use them for everything. And then it's further on down the list, but for wound cleanser, we just use saline. So that isotonic fluid that we've been talking about, 0.9% normal saline, sodium chloride, that is wound wash. So that is what it is. You'll see specific spray cans that say wound wash. It's just normal saline. Before we had those fancy things, we just use saline. Flushes, you'll see nurses all have IV flushes in their pocket in case they need to flush an IV, make sure it's open. We can also use those for wound care if we have it. If the wound is small enough, we can use it to kind of rinse and irrigate the wound. Okay, so gauze and saline are what we use. Band-aids, you know, we need that. There's different types of tape, right? There's plastic and paper tape and silk tape, all different tapes that your facilities will have. Over here, this is called Kerlix. It's just wrap gauze, so if you have to wrap something, sometimes you'll see them like on confused patients if you're worried about them ripping out their IVs. If you think of some of our confused patients, out of sight, out of mind, we kind of distract them. So if you cover it with gauze and they don't see it, sometimes that will last a little bit longer if you keep it covered. This is just like a gauze that's got adhesive built into it that you'll see on the unit. And then up there, it looks like an ACE wrap, but it's not an ACE wrap. It is Coban or Cling, and it's like gauze, like a wrap gauze that sticks to itself, and you can make it compression, like you can make it tight on itself. So it is kind of like a cross between an ACE wrap and like a sticky compression bandage. So you would put it on, and it would be one that would stay on at least a couple days because it's kind of like a big ordeal, and then you just cut them off. It's not like a cast, it's soft and flexible. All right, so those
Is
are.
that what they use like when they draw blood?
Yes, yeah, you'll see them put those on the patients. So if you go and you're doing your morning assessment, I always like to see what's old that I can get off this patient, because that's not gonna be very comfortable for them. So unless somebody just drew their blood and just put it on, get all that old stuff off of them, because that's irritating. Biofilm is kind of like slough. It's just like a yellowy drainage that's on the skin that you might see on a wound, so we would kind of clean that off. These are all just open wounds in various stages. This group here all look infected. That one doesn't look too bad. These two have some yellow, some slough tissue in them. Debridement, we talked about how it can be chemical with like ointments that we put on the skin, or it can be mechanical, which like a surgeon or a provider would cut away the dead tissue. Because if you think about granulation, the refilling of the tissue that has to occur, if there's dead tissue there, there's nowhere for the granulation to occur, so we have to get it out of there, cut it off, and then that tissue can hopefully grow. Some pictures of dehiscence, so you can see up in the top, there's an incision. You can see the old markings from staples that had been in place. So these staples had come out, and then there was an area that opened up there. You can see it's more likely to be on the abdomen just because we turn and bend and move and use our abdomen. Dehiscence. And then the dermis, right, is that second layer under the epidermis, and it's mostly made of connective tissue. Then desiccation, we talked about desiccation versus maceration, so just abnormal skin integrity. Desiccation is like super dry, so it's gonna kind of flake and open, and then you can easily get pathogens, virus, bacteria, anything can enter the skin. Okay, and then the epidermis is that top layer of the skin. And then after granulation occurs and the wound bed fills in, for the skin to kind of cover, it's called epithelialization. So it's the top layer of the skin kind of coming across. So you can see in these pictures, it's already like very superficial, there's really no depth to it, but the sides are kind of shrinking in, and as the epithelial tissue is just growing and connecting and closing that wound up. Erythema, we all know, is redness. There's different reasons for erythema, right? It could be like an allergic reaction or pressure, infection, a burn, different things like that. Okay, eschar kind of goes with necrosis. It's a term for the necrotic tissue that you see. It's like a leathery black scab. Eschar, some people say escar. I just like to say eschar, so that's how I say. But again, it would need to be debrided. It would need to be removed because that tissue is not going to be able to fill in. Evisceration is when the inside organs protrude out. And then here's our pictures of exudate or drainage. We'll go through the different terms for that. Okay, a fistula, we touched on it a little bit with elimination. So you can have a fistula between like your GI and your GU system where there's connections that shouldn't be there. And so both elimination comes out of both parts. And then you can also have it in between wounds. So if a patient has usually you see it if they've had abdominal surgery and lots of abdominal wounds, they have a difficult time healing. There can be connections between the wounds, abnormal openings. So it's just a big problem, a bad complication. Friction is one of our risk factors for pressure injury, right? So when you raise the head of their bed up and they slide down, they are causing friction. It can kind of tear their skin open. The picture of that granulation tissue, it's kind of hard to see. That one's a pretty good one, but on your computer you can see like the little buds of tissue growing. Hematoma, it's kind of like an abscess, but it's not infected drainage, it's just blood. Okay, so you can see there's a boxer, so if he got punched in the eye, so now he's got a big hematoma. It's a bruise, but like worse than a bruise. There's like a collection of fluid under there. And then this is not an uncommon one. So this picture all the way on the left is an incision site from a pacemaker. So if your patient has a pacemaker put in, usually they've got cardiac issues. They probably have a history of taking blood thinners and stuff. So you really have to assess that site closely because it could develop a hematoma. So we need to put pressure on it. If you've had patients, has anybody had a patient go down for a cardiac cath yet? A heart catheterization? No one's had those yet? Oh, that's not fun. All right, well, we'll talk about it at another time. But yeah, hematoma, so when the blood kind of leaks around the tissues. All right, we'll take a break. Anybody have any questions about anything at this